Welcome everyone, and thank you so much for joining us in our Interprofessional Hot Topic series. Just to provide some context for those of you who might have it as their first time to join this series. Every month during the academic year, we select a topic. Actually, the students have selected a topic. And then based on the topic of need, we identify a healthcare team or speakers that could address that topic. In this case, the students identified inequities in healthcare systems as an area of need. And what better team than a powerful duo that has our equity advisor in the Faculty of Health Sciences, Celina Caesar-Chavannes, and our dean, Dr. Jane Philpott, to actually address this area and share some of their experiences with both equities, but also inequities in healthcare systems. I also want to mention that the format today is slightly different. Typically, we were able to see one another, and today we're using the Zoom webinar feature. So you won't be able to see the other participants. However, I can tell you that I can feel the positive energy. I know you're all there. So hopefully that you can feel the energy as well. The other difference today is that we do have the Zoom webinar comes with a Q&A feature. I know some of you are pros at this and have used it in the past, but if you haven't, please use the Q&A and pose questions to both Jane and Celina. As you hear some of their experiences and some of their expertise and some of their stories, I will be monitoring the Q&A, and after we invite both of our guests tonight to share their stories, then we'll open it up for questions. So I will be reading out the questions and we'll do our best to address them. I also want to remind everyone that the session tonight is being recorded. So if you're talking to colleagues tomorrow and say, I attended this wonderful session, it's too bad you weren't there, well, you can get the recording. So please reach out to our office and we're happy to share the recording. I don't know if hopefully I didn't forget anything, but I think we're good to go. And Celina, I'll turn the virtual floor to you. And as I mentioned in our brief conversation, this is mainly for our students, but we have quite a diverse audience tonight, and they're interested to hear a little bit more from your experiences as an educator, an equity advisor, an entrepreneur, an author, your experiences as a citizen or perhaps a patient with the healthcare system. So anything you could share with us, we would be grateful. Okay. And I know you have slides, so we can start those and take it away.
All right, well, thank you so much. I'm grateful to be here. I'm obviously coming in from my home. I'm in Whitby, and I'm situated on the traditional territories of the Mississaugas of Scugog Island. And I'm going to start sharing because it usually takes a while to be able to do that. Oh, it didn't take a while at all. It went so fast. So I really like, I'd like to be able to talk a little bit, as was mentioned, about my experiences within the healthcare system. But I think to those who are on the Zoom call, we need to understand that in as much as we talk about equity within our systems, healthcare, justice, more broadly into education and child welfare, you know, when we talk about quality of life, when we talk about how we want people to live, work, and play and thrive, we really have to understand that our healthcare system has tentacles into everything that we touch. And so I'll be giving some examples that are probably, you may think are outside the healthcare system, but really impact families and their ability to live, work, and play and have a good quality of life. So, oh, I have to click on this. Okay. So I'm going to focus on challenges as a Black parent. One example that I have two children that had Kawasaki disease, and as rare as that is within a Black family, and as rare as it is to have two children with Kawasaki disease, it really gave me an understanding of some of those inequities that can exist. And the reason I'm using this particular example is because we have to understand that some parents are able to advocate for themselves. They understand terminologies, they understand the system. It's unfortunate when you have those that cannot understand the system or don't have adequate access to the system and the challenges that they may face. I will speak a little bit to my entrepreneurship and some of the things that I had to do to be successful in there. And then I'll round it out with Blackness and health outcomes more specifically. So I want to talk about, both of my children. I have a 21-year-old, a 16-year-old, and a 12-year-old. My 21-year-old and my 12-year-old got Kawasaki disease at 5 years old, both of them. And with my daughter, Desiree, when she got Kawasaki disease, we had no idea what it was. We went to the hospital. They said it was a UTI, uterine tract infection, went home with antibiotics. And as a mom, I just really felt in my gut that, if this antibiotic, I have to put the timer on because I could talk forever. So if this antibiotic does not work within, by the next day or so, I don't see any kind of things that make me feel that she's getting better, I'm going to bring her back to the hospital. And remember a time when, for those of you who are familiar with Sick Kids in Toronto, they were saying, please do not bring your child here for everything. There are periphery hospitals that are working just fine. And I thought, if she's not better by tomorrow, we are going straight to Sick Kids because this kid is not well. And for those of you who don't know, Kawasaki disease has a very particular pattern that goes after over 5 days. And by this day, I think we were on day 4, approaching day 5. And we knew something was terribly wrong with her. And so we presented at Sick Kids. The point of what I'm trying to say is when my son came along, we knew exactly what was happening. He presented the very classical symptoms. We brought him in on about day 3 because we knew, day 3 or day 4, because we knew we'd have to wait until day 5 before he got the treatment that he needed for Kawasaki. And when we were there, I believe it was day 4, to be honest, he presented, and the physicians there said to us, well, ma'am, and I said, he's 16 now. He's 12 now. So this is almost 7 to 10 years ago. They said to us, ma'am, your son can't have Kawasaki disease. And I said, no, I'm pretty sure he does. Our daughter had it. And I know that this is what my son has. And they kept insisting that he wouldn't have it. And I said, well, why do you keep saying that? And they said, because his skin isn't turning red. And then it dawned on me that I was in a situation where, oh, of course, Desiree's skin is a lot lighter than my son's, and my son's is as dark as I am. And I said, have you ever seen Black skin turn red? And then they went quiet because I was like, oh my goodness, we've just never encountered this before. And I said, look, I understand that this may not be something that you've encountered before, but this is exactly what's happening. I know my son, his skin, especially along his legs, are clearly red. And, that's when they got the cameras out and started taking pictures, and, it was a process. But when we're looking at health outcomes, we really have to think about the fact that, one, maybe your experience has never allowed you to see certain things. And I know Queens has just got the DX visual system, right? That was some advocacy done by a lot of students. And I don't know if Jane will speak to that, but hopefully we could talk about that in the questions. But that offers opportunity for us to really have an advantage, not just for Black physicians, but for all physicians to be able to understand what the skin types look like. But also it's a conversation about access. Who is able to advocate? Are they able to advocate? And can, within a healthcare system, can that advocacy really happen? And I mean, I think everybody has heard stories about pain and Black skin, 2020 report by Janice Sabin talking about medical trainees who believe myths that Black people have thicker skin and so don't require pain treatment. And I want people to understand that this is not just an American data. We had in 2019, Matthew Drew, I believe his name is, present to a hospital 5 times before he got the treatment necessary for him to get a spinal tap for his meningitis. So it really presents a problem when there's inequities in the system. And if I could speak a little bit now to, just being a Black woman in the research industry. And I use this slide really just to show a little bit of my life, or we're just going to talk about this piece right here as an entrepreneur between 2005 and 2015. And, of course, the life after that is a very public life in politics. Everybody knows exactly who I am. My early years, did very well in high school, not so well in university, but really had a good foundation, solid foundation of who I was. But here as an entrepreneur, I owned a healthcare-based research management firm. And as many may or may not know, the research industry is really a white dominated space. And working in neurological research in particular, I'm not a researcher. I managed clinical trials or managed co-chaired epidemiology studies. I understood the business of research. And being in that business, I was very conscious of the fact that I would probably be a lone person, either as a woman or as a woman of color or as a Black woman in particular. And as such, when I started my company in 2005, and I'll say that this lasted till maybe around 2012, I didn't show my face. I hid everything that identified me as a woman, or in particular as a Black woman in this space. And I did that on purpose. You can't do that when you're in politics. Of course, that's a very public space. You can't hide who you are. But here, I just didn't want to have to deal with the consequences of not getting clients because they didn't want to work with a Black person, or they didn't want to work with a woman, or they didn't want to work with a young person, or whatever other discriminatory factors could have been at play in me starting up my business. And I say that happened from 2005 to 2012, because in 2012, I won the Toronto Board of Trade Entrepreneur of the Year, and it was very difficult to hide after that. But up until that point, I usually wouldn't see any clients until we had signed, executed agreements, we were already starting to work, everybody was making money. And at that point, nobody cares what color you are, right? As long as the service is good and people are doing well. And I mean, I think that that's critically important, especially when we're talking about right now, COVID-19 and the hesitancy of individuals, especially in Black and Indigenous communities of color. There's whole strategies from the city of Toronto to get people to reduce that hesitancy and to start getting medication. During that time, I spoke a lot about the inclusion of marginalized people in clinical research and how important it was. And how important it was not only for them to be involved, but for them to get the invitation to be involved in clinical research. And it's a tricky place to be, because as a Black woman in this space, you want to highlight the fact of how research is done, how it's done properly, how it follows certain protocols. But then I'm also very much aware of the historical challenges of research and Blackness, research and indigeneity within Canada and the United States and around the world. Pfizer has made a vaccine for COVID, but if you just Google Pfizer and Nigeria, the results are devastating for some clinical trials that were run there that were not executed properly. So it really is a challenge in the research industry as a person of color, as a Black woman, to want people to get the best care possible, but understanding that that people have been taken advantage of within the system, and understanding that right now we need people to sort of understand how important it is to get the vaccine. And so for my last slide, I just want to talk about Blackness and health outcomes. And I'll start with the middle first, because we're talking about COVID-19. And I guess what I want people to understand from this is that, you know, when we talk about health outcomes, it impacts on the individual basis, it impacts on the systems basis, and you know, when you have racism within a system, it promotes inequality. And when you're thinking about an anti-racist framework, you're either looking at decisions that are made that either promote equity or promote equity, meaning people are the same, or promote inequity within the system. And talking about COVID-19, I know I have old numbers here. I think Toronto has numbers from October 2020 now. But in April of 2020, two governments had an opportunity to make a decision around promoting equity or inequity within Ontario. The Ontario government and the City of Toronto were receiving information that clearly said from the United States that Black people were being adversely impacted by COVID-19. The data was coming in, and at the time, Ontario made the decision to say that they were not going to collect race-based data because, you know, COVID-19 does not discriminate. Everybody gets it. The virus is impacting people in the same way. The City of Toronto, based on some advocacy from a lot of different groups, said, no, we are going to try to look at creating some equity and starting to collect race-based data when we look at COVID-19. And we see, based on the fact that they collected this data, that although the City of Toronto has a population of 9% that are Black, they are impacted by COVID-19 to the tune of 25%, hospitalizations 24% for such a small population. The population of the City of Toronto, 52% are racialized individuals, and they are impacted by almost 80% of the burden of COVID-19. So when we talk about health outcomes, we really have to pay attention to these inequities, and we really have to gather the data. We can't guess. This is not a guessing game anymore as to how that works. But I want to talk about on a more granular level when we talk about microaggressions. And I don't like using the term microaggressions any more than I like talking about unconscious bias. Because we've been talking about unconscious bias for so long that at some point you need to ask yourself whether it is still unconscious or whether you're making a conscious decision to do certain things, and it's just willful ignorance at this point. When we talk about microaggressions, death by 1,000 cuts when you make these microaggressions towards not just racialized people, persons with disabilities, different genders, religious minorities, etc. You know, whether you are making a microaggression, which is a death by 1,000 cuts, or being blatantly racist, it still has that impact. And in 2018, you know, there was articles coming out of the American Psychological Association talking about the trauma that is inflicted on people when they have to daily deal with microaggressions, daily deal with people's unconscious bias, and the words that they say, the seemingly innocuous jokes that are met that make people feel that they don't belong, that make people feel that they don't belong in a system, or that there isn't equity in that system. And that trauma is because most of the time we are told when someone just, decides that they're going to touch my hair and say, oh, it's so curly today, and feel that they have the right to assault me, essentially is what they're doing by running their fingers through my hair. Because I know that I couldn't do that to Jane on a regular basis, just, run my fingers through her hair. That is just something I wouldn't even think to do, because it's just something that you don't do. But as a Black individual, I can't tell you the amount of times that somebody has either touched my hair or touched my braids or done this kind of stuff. And we are told, instead of being able to report it and have consequences, we are told, well, why are you being so sensitive? Oh my goodness, I was just joking. Get thicker skin, and it's dismissed. And so therefore we have to internalize that behavior. We are the ones, although we're the victims, have to still internalize it and never get justice. And that creates a pattern where it physically, mentally, and I think spiritually as well impacts us as individuals. But when we look at the system more broadly, and I put this this picture from the Ontario Child Welfare Associations up, just to really highlight, and people could take the time to go in and look at it themselves. I'm not going to stay too long. But when we look at how Blackness in particular impacts health outcomes, it impacts it at every single level on the continuum. There in the city of Toronto, again, a city that only has 9% population of Black individuals, they have 40% of their children in care are Black. And at every level of the child entering the system, the child in the system, and the child exiting the system, there are decisions that are made that further perpetuate that inequity instead of creating equity. So whether it is that the fact that children exit the system as Black individuals, they don't get returned to their families, as do many white children get returned to their families, get an opportunity to then exit the system through a process that allows for care, that allows for them to be treated with dignity. Black children are often exited out, meaning they age out of the system, and they have a higher propensity to not finish school, have teen pregnancy, to enter into the criminal justice system. And there the cycle then sort of perpetuates itself from childhood into adulthood. So I'll leave it there for now, and I'll turn it back. But I hope that there are questions after that we could dig a little bit deeper into some of these issues.
Celina, thank you so much for sharing different aspects of an interconnected story, because they all really come down to everything that we do, and we all have influence, could either combat and dismantle or could promote inequity. And we'll come back for a more fulsome conversation, because I already see some comments in the Q&A, but I'd like to turn the floor to our Dean next, and then maybe we can connect everything that was said together, and then address some of the questions that are coming in. But thank you for now.
Thank you.
Dr. Philpott.
Thank you very much, Claudiana, and thank you to the Office of Professional Development and Educational Scholarship for hosting this interprofessional event, and I'm honored to be asked to speak on this theme, and I'm particularly delighted to be joined by my friend and colleague, Celina. And I will just say that we're very grateful that we have had Celina here with us now for well, I've only been here 7 months, so you've been here less than that, but you've already had such a big influence on the faculty, and we've appreciated it. And Celina didn't even take the opportunity to pitch her book. She's a published author now. Her book came out just under a week ago, but it's hit the bookstores by storm. I'm reading it myself and absolutely loving it and learning things about Celina that I didn't know, even though I've known her for a number of years now. It's really quite exceptionally well written, and it's an amazing story. It's brave, and you can't read it without learning a lot, not just about Celina, but about life. So strongly encourage that. We're proud to have another author in our team here at Queen's. So, all right, I've been asked to take on the same topic, and I will just share my slides, if I may here. Let me just see if I can get this right. Share screen, ta-da. Let's just get to the right slide, and then I will. Wonderful, okay, so yes, thank you very much for inviting me to speak on the same topic of inequity in health systems. And I will share that I am in Kingston, which is the traditional territory of a number of Indigenous peoples. These lands have been lived on by people who are Haudenosaunee, who are Anishinaabe. At different time periods in time, the Huron-Wendat peoples have lived on these lands. And now Kingston and the region are home to a number of Indigenous peoples, and we are indeed grateful to be able to share this absolutely beautiful piece of Turtle Island together, and thankful for those who've cared for the land over millennia. So as we talk about inequity in health systems, and particularly thinking about us as a faculty of health sciences, I have elected to talk about what the roadmap might be to get to the point from inequity to equity, and see how far we can actually get along that road together. So my basic outline is that we'll talk a little bit about why I think we need that roadmap to equity. What is our actual destination? Because you'll never get anywhere if you don't know where you're trying to get. But more specifically, I'll focus on how I think we might most efficiently get there together. When one asks the question about health systems and why we need a roadmap to equity, this to me is a photo that kind of captures the essence of what we're doing here. This is the picture of Joyce Echaquan's widower. Joyce Echaquan, as you may know, back in late September, died in a Quebec hospital as a result of racism in the health system, that her illness was not appropriately treated, and she was the victim or the recipient of racist approach by the health system, and she died as a result, leaving her husband and her children. And it's an extraordinary tragedy. Unfortunately, it's not an exceptional story. And in fact, there are stories all the time about incidents of anti-Indigenous racism, anti-Black racism, and other forms of racism in a number of different institutions, including health systems. And this is just a small sampling of the kinds of stories that we see over and over again. If you follow CBC Indigenous website, you'll see stories of coerced sterilization of Indigenous women. You'll see stories like the Joyce Echaquan story and the well-known story of Brian Sinclair and his death. We also see, of course, the dramatic overrepresentation of Indigenous peoples who have tuberculosis at rates amongst the Inuit that are 300 times the rate that of Canadian-born non-Indigenous peoples. And we see rates of suicide in racialized people that are far higher than in the white population particularly. And one of the tremendous tragedies, particularly with Indigenous peoples, is the very young girls that die by suicide. And this is not a phenomenon that's commonly seen in many other communities. So this is something that's obviously been talked about for a very long time in health systems, but I think it's fair to say, in the context of 2020 and 2021, an awakening to racism in general in society. It will be our responsibility in this generation to respond appropriately. But in terms of racism in health systems, as a result of Joyce Echaquan's death, there's been an unleashing of interest in addressing racism. But there's also a study that was done very recently in British Columbia as a result of an incident that was discovered in a British Columbia emergency department room where people were playing games and had established a game to try to determine the blood alcohol level of Indigenous peoples who showed up in the emergency department. This led to an inquiry, a provincial inquiry in BC. I strongly recommend that people have a look at this report called In Plain Sight, which is one of the best recent attempts to actually try to quantify the amount of racism that takes place in health systems. In that study, which was conducted by a group led by a wonderful judge by the name of Mary-Ellen Turpel-Lafont, and they determined in the wide range of participants in her study, or in the inquiry, that 59% of Indigenous respondents had witnessed interpersonal racism or discrimination directed at Indigenous patients in British Columbia health systems. And they started to try to dig into what the reasons for were. And I think this will be a clue for us as we start to try to think about what our role is in response to this. In some cases, it was staff not willing to stand up or call out behavior. So people seem to think that it was okay not to say anything. 38% of the staff said that they had not been reminded about how discrimination can occur. And of course, this phenomenon that Indigenous peoples are underrepresented at all levels of health systems. So each of those top reasons in and of itself gives a clue as to what we can do on the roadmap to equity. There are a number of recommendations in the report. Some of them are things that I think do speak to us as an academic health sciences institution in terms of setting standards for Indigenous cultural safety, finding measurement ways to be able to measure whether those standards are being set. Developing pandemic response. Celina talked a little bit about the pandemic response and the racialized manner in which it has been addressed. And specifically in the bottom middle of these recommendations, you'll see that healthcare degrees should require documentation of a knowledge of Indigenous specific racism. As well as the recruitment of Indigenous people, and one could extrapolate this to other racialized people to senior positions within health systems. So a pretty decent roadmap there. But, if I sort of come to what is the why as to our obligations to be able to find our way toward equity, is that it's not just about the outcomes for any particular group of people, but it matters to everybody. It matters to every person who lives on the planet. Martin Luther King Jr. famously said that injustice anywhere is a threat to justice everywhere. And I like to extrapolate this and say that I believe that ill health anywhere is a threat to wellness everywhere. And I don't think that we will ever be well, that we will be whole as a people, as a society, while we leave large segments of society continuing to wallow in illness as a result of racism and other forms of discrimination. So what's the destination? What is it we're after, and why do we really want to see equity in health systems and in health professions education? And to me, the destiny is health for all. I mean, if I were to kind of think of what our whole goal is together as a faculty, what is our whole goal, all of us who are in health professions and health sciences, is really to be able to live in a world where everybody will have fair, safe, and equal access to healthcare, but in order that they will ultimately have health outcomes and a healthy way of life for every person on the planet. But we will only achieve that health for all if our focus is squarely on equity. We spend a lot of time looking at all kinds of other issues that are part of the biosciences. We spend a lot of time focused on issues of technology, on issues of pharmacology, on biology, but it really will be essential for us in order to achieve health for all to make sure that equity is the foremost focus of the work that we do. Canada has struggled to be able to get there. I like this quote from the Royal Commission of Aboriginal Peoples because it does give me some measure of hope and some measure of a belief that Canada can, in fact, be a test case for a grand notion. This is a report that's now 25 years old. It's a fantastic report. I strongly recommend reading at least the highlights of the Royal Commission. It's the whole thing is a 5,000-page, 5-volume report. But if you Google highlights of the Royal Commission, you'll see a fantastic, relatively brief report that's quite readable. And it opens with these two sentences: that Canada is a test case for a grand notion. The notion that dissimilar peoples can share lands, resources, power, and dreams while respecting and sustaining their differences. Alas, the story of Canada is the story of many such peoples trying and failing, but always trying again to live together in peace and harmony. And that's what we're hoping to achieve through equity, is that grand notion of living together in peace and harmony. Well, how are we going to get there? I'd like to propose 6 principles, and I would look forward to feedback on any portion of this talk, but in particular, you can help me maybe add to the kinds of principles. But here's 6 of the principles that I think need to be involved in our collective journey together toward equity. And I'll go through each one of them in particular. I think there need to be some sort of guardrails or sort of a bottom line that we need to establish in our work. We have a lot of work to do to educate. We need to be comprehensive, collaborative, rooted in human rights, and respectful of autonomy. So let's go through each of those in turn. Number one, and this actually came out of a conversation that I had with some of the team that are involved in the Equity and Diversity and Inclusion Office about the fact that we really need to just establish a very clear baseline of what the expectations are at the Faculty of Health Sciences. We can't control everything about the university. We can't control everything about all the health systems that run across our community, but we can control things within, or we can at least set a standard in the Faculty of Health Sciences. And I would like to propose that we make it very clear that we have a standard that we will not tolerate harassment or discrimination of any kind. This is not just about racism. This is about ageism. This is about ableism. This is about sexism. And there seems that there are some kinds of harassment and discrimination where the message has gotten through. It's very clear that if someone is sexually assaulted or violated, that people understand that that is absolutely beyond what is acceptable, and it's reported, and it's very clear that that is not ever to be tolerated. In healthcare, we get very clear guidelines around things like child abuse, and everybody knows that not only do you have to have evidence, but even if you suspect that someone has been abused as a child, that will absolutely not be tolerated, and we have very clear mechanisms in place. But somehow it seems that certain types of harassment and discrimination, people feel like that the same kinds of standards don't have to be set. And I'm going to do some more thinking and talking and writing about this, but I propose that we need to understand clearly and respectfully among one another that we will not tolerate any kind of harassment or discrimination in this place, that it will be very clear to everybody the work that we all have to do to prevent that, but also that it will be equally clear how you should respond so that we don't end up in the case that was described in British Columbia, where a large proportion of the people who witnessed acts of racism in health systems didn't report it, possibly because they didn't know what to do, and it wasn't clear that it was not to be tolerated. Number 2, we need to educate everyone. This is really a collective project for all of us to do. I'm showing a picture here of one of my favorite books that if you're looking, we'll do lots more, we'll continue to do lots more work along with the Office of Professional Development and Educational Scholarship and all of our other resources that we have to make sure everybody knows the kinds of reading that can be done. You can't actually see the title of this book, but it's called Up Ghost River, and it's by Edmund Matata-Waban, one of the most wonderful, well, one of the most difficult books, but educational books for me about residential schools. And I'm standing beside Edmund Matata-Waban, an extraordinary person who's actually an officer of the Order of Canada now, but a very long time ago, he grew up in St. Anne's Residential School, where he was exposed to the electric chair as a punishment, where he endured a tremendous amount of trauma, but managed to survive it, and lives in this beautiful log cabin in Fort Albany along the James Bay, and wrote a book about his experiences in residential school. So that's one little resource that is the kind of thing that we need to encourage one another to read so that we are all educating one another. And I think we have a lot to educate one another about in terms of the links between inequity and health outcomes. So people kind of still don't understand that those are deeply linked together. They think we've got a whole lot of work to do around making people healthy, and we've got work to do around equity. But what I'd like us to increasingly understand is that the reason that people are often experiencing those kind of health outcome gaps is because of the inequities that exist. And in the case of Indigenous peoples, those health outcome gaps are not by coincidence, as Celina pointed out to earlier. It's not a coincidence that Black people have experienced higher numbers of COVID in the city of Toronto. But health outcomes gaps have their roots in the laws, policies, and practices of our country, our province, our municipalities. In the case of Indigenous peoples, those policies include things like residential schools, forced mass resettlement, and intentional cultural oppression. And those are the kinds of educations that we need to teach people about. And, you know, we talk a lot about just determinants of health, but racism and colonialism are determinants of health upon which all other determinants of health are constructed. So issues of housing, issues of shortages of education, of poverty, are often rooted in these more profound distal determinants of health, including racism and colonialism. So how do we respond to this? Well, I hope if you've ever heard me talk about this before, you've heard me use the word comprehensive. Our response really has to be comprehensive. And I think that message everybody's pretty on board with. And I'm absolutely delighted to see that we have tried to undertake that approach together. You've probably seen this slide over and over again. You're going to keep seeing it over and over again until we get our work done. But this outlines some of the pieces of work that we've been doing through the Dean's Action Table on equity, diversity, and inclusion. And I cannot overemphasize how impressed I have been by the work of the now over 160 volunteers who have been helping out, again, supported by OpDes and others, and by the Office of EDI, to be able to look at things like outreach and summer programs, to look at our admissions processes and recruitment and curriculum, professional development, research, and culture and community. And each of these subtables has been tasked with doing a comprehensive literature review, extraordinary scholarly work that's being undertaken at the moment. They will come back with a view of best practices. They will come back with some recommendations for all of the schools. And I think it's really an exceptional piece of work. And we look forward to, hopefully by this coming September, having some reporting back from that table. And I think everybody will be well informed by that. Some of the comprehensive work that we've been doing is outlined just for your encouragement. I suggest that you have a look at the EDI page, and specifically a list of initiatives that are undertaken. And this is all kind of happening somewhat organically. And I just have to say, again, I'm really impressed with the work that's happening. And we're seeing wonderful collaboration, so that the Department of Family Medicine, for instance, decided to put together a volume of their Horizons magazine on issues of Black, Indigenous, and people of color in health sciences. If you haven't read it yet, have a look at that edition. We have faculty, staff, and students who have written articles within that. Share it widely. It's absolutely superb. The EDI office has done a bunch of work on developing a style guide around language and writing associated with issues of equity, where students are going to be sharing that widely. And I think it's going to be very popular, and much more comprehensive work is happening. But let's look specifically a little bit at the issue of curriculum, which is one of those comprehensive pieces of work. And as you probably should all know well now, the Truth and Reconciliation Commission has a specific recommendations around curriculum and the kinds of things that need to be included in health professions training around intercultural competency, conflict resolution, human rights, and anti-racism. And I know that a lot of work has been happening at Queen's in that regard. But more recently, we've seen people really digging in much greater detail in terms of what the curriculum is like. And I want to give a big shout out. I don't know whether any of them are listening today, but there's a group of about 120 students in the undergraduate medical education program who undertook this incredible project where they looked at about 1,000 different learning events in their curriculum, and started to look at this issue that Celina raised around the presentation of skin conditions, and how many of those skin conditions were being presented in white skin, and how many of them involved Black skin. And they came up with this really impressive piece of work, suggesting that there needed to be ways to be able to adjust the curriculum so that there were not only white and Caucasian stock images that were used in lectures. And so this is a piece of work that I'm hoping they are planning to publish, and they are apparently not done yet. They're going to continue this kind of fine-tooth combing through the curriculum. And this is what I'm really loving, that I'm seeing people are starting to say, it's not just about adding a course here and a course there. It's about combing through the curriculum to find those pieces of the curriculum where where there are inherent and implicit biases into the kind of content that's there. Some are not just implicit bias, some are just out and out bias and discrimination. But what are the ways that we are not achieving equity in our curriculum? And I think we really have an incredible opportunity here at Queen's to do that kind of comprehensive overview. And what some of us have been talking about in terms of revising our curriculum in equity-based education for health professions is making sure that we understand, yes, we have stuff to add around cultural safety and anti-racism and anti-oppression, but it's not just what we add to the curriculum, it's also what we're going to subtract. It's taking out those overt pieces of racism or sexism or ableism, but also those more hidden curricula pieces. And it's how that curriculum is delivered in terms of the ways that we teach and the ways that we assess and what needs to be changed and what does decolonizing look like when it comes to what you add, what you subtract, and how you deliver that curriculum. And so I'm really encouraging, this is one of my favorite slides, you probably have seen this before, but that our goal here as our path to equity is not the patchwork, not just to slap a little bit of this here and a little bit of fix it up there, but we want to see equity woven through everything we do, how we relate to one another, who we are, who is represented, who is heard, and that I think is what will really make the work of Queen's be different and effective in achieving our goal of equity. The fourth principle, I think, is that we have to be collaborative. And some of this is obvious, but I really want to state it. This whole course is about being interprofessional. We will not achieve equity unless we work together across the health professions. It has to be highly intersectional. And that, of course, means that there are multiple ways in which people can face harassment, discrimination, inequity. And we need to realize that those are cumulative and they build on one another in ways that are profound. And we have a responsibility to recognize that. We need to work across institutions. If we do all kinds of fantastic work to achieve equity as a faculty of health sciences, but the hospital and the clinics in this city and in this community are not equally joining us in this journey, it won't help. And we need to be intersectoral, as Celina referred to earlier, in terms of looking at education, social services, etc. But I really want to emphasize this point about interprofessionalism. That's what the theme of this rounds is. And I would have to say that we need to realize we will not achieve equity outside our health teams unless we respect one another within our health teams. And if you don't take home any other take-home message today, that's the one to take home. And so here's another place where there will be zero tolerance. We will not tolerate somebody thinking that any kind of health professional is any better or more important than any other health professional in the Faculty of Health Sciences, or well beyond the schools that are represented in the Faculty of Health Sciences. The reason we have multiple kinds of health professionals is because we need every one of them. And every single one is an equally important player on the team. And we will not have within those professions people thinking that one specialty is more important than another, that primary care is more or less important than specialty care. We have to achieve equity within our health teams before we can, and respecting one another within our health teams if we want to be able to achieve equity on the outside. I know I've taken up too much of your time, so I'm going to fly through these last few, but please, we have to be rooted in human rights. That's the whole point here, is the recognition of our shared humanity, that every human life is of value and those lives are rights-bearing. This is a picture of Jordan River Anderson, who inspired the work around Jordan's Principle, which was has been highly effective in addressing discrimination against Indigenous children. And it took the Canadian Human Rights Tribunal before Jordan's principle was recognized. So much of healthcare is above the surface, and we have to get down to the roots of human rights. We've learned pretty well about social determinants of health. We've learned that you have to dig deeper than the clinical, and we're pretty good at letting people know that you have to look at all of these social determinants, but that's actually not the roots of the issue. And the Truth and Reconciliation gets at this when it talks about the fact that those health outcomes are the direct result of government policies, but they go beyond that, and they say the way that you get at the roots of the problem are looking at the healthcare rights of Aboriginal people. The same could be said about the health and human rights of other racialized people. So that better care requires not just addressing the social determinants of health, but recognizing those human rights. In the case of Indigenous peoples, they are bound up in international law, in the United Nations Declaration on the Rights of Indigenous People. There are also, of course, inherent rights, and there are universal human rights that are at the roots of our work in equity. And the last thing I wanted to just say was the importance of respecting autonomy. And this is something that's really important no matter what particular group that we're speaking of. In the case, as most of this talk has been focused on looking at Indigenous issues, and the reality, again, 25 years ago, documented in the Royal Commission on Aboriginal Peoples, that what Indigenous peoples want is not pity or handouts. What they seek most of all is control over their own lives. And I think the more that we understand what happens when we take away people's autonomy, when we take away their ability to self-determine, is perhaps one of the most important pieces of the recognition of rights. That's very specific right to self-determination, one of the most fundamental necessities in the human hierarchy of needs. And the most important piece about respecting autonomy is this fundamental principle that the work that we do should always fall by the guidelines that there should be nothing about us without us. And it's pretty hard for us to do that together if we don't have widespread recognition of the people that we're trying to support and to care for. And this is one of the reasons that we really need to seek greater diversity, greater inclusivity in who we are, so that we can respect that autonomy. And with that, I will wrap up my principles and look forward to questions and comments.
Thank you so much, Dr. Philpott. Thank you for sharing with us some difficult truths that we needed to listen to, but also for emphasizing again and again that the message that we won't really achieve equity until we respect one another and we respect our agency that we have. Thank you for that. I will turn now to some of the comments and questions. In the first one, I see it more as a comment directed to Celina. Hi, Celina. We're self-experienced, and we also heard from others that who gets COVID-19 testing done is also influenced by one's race, even when one has symptoms. I don't know, Celina, if you wanted to comment further on that. I think it went back to your conversation and what you're sharing about some of the data that's coming out from the pandemic.
Yeah, so it's not just about race. It's also looking at a zip code or a postal code where people live. And, you know, when you look at some of these hot spots, you have to kind of figure out, you know, Jane talked about the social determinants of health. Well, you have buildings that are built like prisons. The only difference between the prison and those buildings is that people could open their front door and walk outside, but the air is circulated within those buildings. It's poorly constructed. So when we talk about the social determinants of health, and we're talking about, you know, Jane mentioned our shared humanity, we have to kind of like, you know, question, why are these hotspots that exist in the city of Toronto in particular? Why do they exist? And, you know, what is contributing to individuals getting COVID-19 and dying at alarming rates, usually women of color in some of these hotspots? You know, the medical professionals are not just talking about the medicine here, they're also talking about access based on the amount of people that have to work They can't go get their vaccine. They can't take time off work to get testing. They don't get paid benefits. They don't have childcare. The infrastructure is poor. And so if our shared humanity is supposed to fix this problem, then our shared humanity has to raise the alarm or sound the alarm on these problems. It's not because these hot zones are not in areas that impact us necessarily in our privileged spaces, but it is because we have a shared responsibility to ensure that there's equity. So I hope that with COVID-19, that there is, a light, a very bright light that's shining in on some of these inequities that are only going to get worse. They're only going to get worse. We're in a pandemic. We're talking about racial inequality. Climate change hasn't gone anywhere, in case we were wondering. And all of those shocks to our economic, social, and political systems tend to impact the poorest and most vulnerable among us. And if COVID-19 doesn't give us the pause to not only address our health outcomes, but also our social outcomes, everything that impacts the social determinants of health, then we would have wasted this opportunity. And I've said many times here at Queen's that we don't just need to seize opportunities to do better, we have to capitalize on them to ensure that everybody gets the equity that they need.
Absolutely, absolutely. Thank you for that, Celina. I think, Jane, this question is directed to you. It's easy to record and report, for example, in assault or abuse. It gets challenging when it comes to record and report passive aggression and belittlement treatment that is more commonly experienced by people of color and can damage one's mental health on a long-term basis. Some guidance on this will be good.
Thanks. Well, I'll take a first crack at that, but I think Celina might also have something helpful to add. And I think it's actually a very good point. And I don't want to assume that we're going to be able to address everything through being clear about a zero tolerance policy in terms of obviously there are some cases that are more obvious than others when a person has experienced an assault, whether a sexual assault or some other kinds of harassment in the workplace, or a racial slur. Those are more obvious things to be able to report and address. I think the person who asked the question is quite right that you can't, there's passive aggression, there are microaggressions, there are attitudes that are sometimes a lot harder to be able to pin down. Here's where I think we really need to try and figure out what we can collectively do together. And I have to give a shout out to Dan Howes, who is one of the simulation lab experts. And I actually put this challenge to him. I said, could you help us develop in our simulations and in our experiences of trying to imagine what happens when you're in a situation where someone has said something to you that they may not have understood, that it was one of those cuts, those microaggressions, not a physical cut, but in something in the way a person spoke to you or implied something about you. And these are much more difficult to address, but we need to figure out together how we can learn to say in a respectful way that's not going to escalate the problem. When you said this to me, here's how it made me feel. And if we can find a way to learn those patterns, not only of speaking up or saying, not when you said that to me, but when the one student said something to another student or a faculty to a resident, whatever it happens to be, we need to find ways to respectfully identify those kinds of circumstances and train one another to be able to respond to them appropriately so that those 1,000 cuts don't add up to somebody having long-term mental health issues because of all of the ways that they have been mistreated along the way. So I'm not an expert in this field, but I think that together, if we are determined to make this a place that is safe and fair and inclusive, and that is our goal here at the Queen's Faculty of Health Sciences, to be a place that people can work and learn, where they will be safe, where they will be treated fairly, where their voice will be included in the conversation. I think we can get there together with our collective determination to walk the path toward equity.
If you don't mind me jumping in on this as well. Yeah, so I did speak about in my presentation microaggressions and the American Psychological Association talking about the trauma that is associated with that, a pattern called weathering and what that does, especially it was studied in Black bodies and how the health outcomes are so much worse when we add on our daily stresses compounded with daily microaggressions, be it racism, ableism, etc. But those with multiple intersecting identities tend to have to deal with this more. And I'm just going to say two things about this point. The first is that I'm going to speak specifically to allyship because I think that's critically important. It's very difficult, and I'd say, Jane mentioned saying, when you said that this is how it made me feel. It's very difficult sometimes to be able to do that in the moment, only because during that moment you are shocked. Again, if somebody runs their fingers through your hair or puts their hand on someone's leg and squeezes it, there is a reporting structure for that. When somebody puts their hands through my braids or my hair, I can't report. What do I report on, right? People are telling me that I need to just take it easy. So during that moment, I have been assaulted. That is an assault on me. As a Black woman, most days I have to either deal with the sexism that I face or the racism that I face. And sometimes I just can't deal with both because they're both coming equally strong. So sometimes I'm just like, you know what, I'm not going to deal with the sexism today, but please, I'll have to deal with the racism today. And this is the issue with multiple intersecting identities. So you need the allies that hear something or see somebody put their hands through, and then you could say, I'm sorry, why did you do that? Why did you say that? And that allows me to at least be able to breathe a little during that moment. But Richard Livingston, in I think the September 2020 issue of the Harvard Business Review, wrote a wonderful piece on increasing equity in the workplace. And he talked about his press model where, you identify the problem, you identify the roots of the problem, you have the empathy, you put the strategy, and then you put the resources in place to create equity. I want to talk about the empathy piece because that is critically important when you're talking about allyship. Now, to get to empathy, to get up to a point where you're actually doing something, meaning you're acting when you see some kind of discrimination happen, there's 4 ways to get there. One is you don't do anything at all. You actually jump in and you add insult to injury by just adding to that racist behavior. 2, you do nothing. You just turn your blind eye and do nothing about it. 3 is you're sympathetic. Let's bake cookies for Celina because she feels badly that somebody put their fingers through her hair. Or 4, you have empathy where you act, where you actually say something and or do something in that moment that allows me to recognize that somebody else in the room understands that I'm feeling the way that I'm feeling because you have assaulted me. And I think that this is where we're talking, when we're talking about we're all in this together, that is critically important. That it's not just upon me who has been assaulted to then say, I'm sorry, why did you do that? But it's for other people in the room. Anytime you feel that sort of knot in your stomach or your eyebrow raises a little bit, or you get that little twitch that says, did that just happen to Celina? That's where you need to jump in and say something. And again, with racism, I don't think, and Jane spoke to that there is, this reporting structure that is necessary. There's some things that we know exactly what we're supposed to do with. Somebody says, your skirt looks great on those legs, you know exactly what to do. But when there's racism, when there's microaggressions, we don't know exactly what to do. And I think, again, the urgency of this moment requires institutions to seize and capitalize on this moment by thinking about these things differently, and therefore putting in the accountability framework that is necessary to start addressing some of these issues.
Thank you so much for that, Celina, and for actually so nicely putting the two together, the critical allyship and the empathy, and how they go hand in hand and you can't separate the two. So, Thank you. Thank you for that. I'm keeping an eye on the chat, and there is another question about someone is saying, I wrestle with balancing nothing about us without us and imposing a minority tax on my BIPOC colleagues. Can you provide some advice on how to navigate this? It's a good question.
Do you want me to go with that and then?
Yeah, go ahead.
Okay. Okay, so the concept of a minority tax, for those who aren't familiar with the concept, is just this reality of the fact that often the people who are most traumatized or victimized by whatever the type of inequity might be, or harassment or discrimination, are the ones who have to do all the work to be able to fix, to educate, to constantly be explaining, constantly be identifying, and that's both physically and mentally, emotionally exhausting, but also it takes people's time. And, you know, if you're the student in the class that has to constantly be able to explain, you know, what residential schools are, for example, that's an enormous burden on small numbers of individuals. So how do we deal with this and also respond to the nothing about us without us? And it's actually a fantastic question. I have a couple of thoughts on that in terms of what we're trying to do here locally at the Faculty of Health Sciences. You know, we've got more work to do, but one of the things that I'm happy about is that we at least have a small staff now in the EDI office who have taken on some of this hard burden. It's hard on them then, of course, you know, the likes of Celina, Courtney Clark, Wendy Phillips, who are, and Giselle Valorizo are doing some of the hard work and getting paid to do it. So that takes some of the burden off students to always, or faculty who may otherwise have had to do some of this work, that they've got some supports, mentorship, etc., and that they don't have to do all of it. We're looking for more opportunities, and hopefully you'll hear more about this in the months to come, of how we can provide support or studentships for students who want to be able to work on projects to address inequities. And then the third thing I would say is to go to the allyship piece. And I think this is where it's a little bit harder, but when trust relationships do build up, there are sometimes opportunities for allies to do some of this work. So I'm thinking, for example, I was interviewed for a research study that the University of Calgary is doing on racism in medical school. And it was commissioned by in particular, I believe, Black medical students, but they chose the person to do the study who is Caucasian, and they selected her to lead the study as an ally who they trusted. It was very hard because of the kinds of questions that were being asked, and that many of them felt that they didn't want to. They wanted to manage their exposure to the trauma, but that they were able to delegate. And so, you know, I'd be interested in Celina's views on to what extent one can delegate work that can say, I don't want you to do this work without us, but I personally can't do it all. And so I will ask you, my ally, to support me in this work. So those are some of the ways to get around that, but I'm not sure that it's a fulsome answer.
So yeah, so absolutely, it's a start of an answer, but I do want to acknowledge Aaron put out something in the chat, and I just want to say thank you to Aaron for putting that. I think we all have a long way to go, so that's no problem. But yes, that's part of the answer in dealing with sort of this tax, we call it, you know, Black tax that we pay, where allies have the empathy, have the skills to say, well, I could start to answer this question, but then we could bring in other people because we don't have a fulsome answer. We understand that whether we're talking about, you know, we're trying to develop policy around, you know, poverty, but the only people sitting at the table are people like in fancy suits. Like, no, you have to bring other people in who've actually experienced it in order to develop the policy, so that the policy can mesh with the lived experience. Otherwise, it's what are you doing? Like, if you never lived it, how do you know your policy is going to work? But I'd say a couple of things in dealing with the tax. one of the things that we have to think about tax in the way that was mentioned in the question, but also oftentimes we're the only ones in the room, right? So I remember even being in Parliament and we have Wednesday caucus meetings. I could never miss a caucus meeting ever, because all you have to do is look around the room and you'd be like, oh, where's the black one? She's not here today. And you'd know, like, that is taxing. Even if you're not well, you always have to be in the room, right? It just doesn't matter, because people will know that the one chocolate chip in the cookie is missing, right? So I wanted to think about the tax differently a little bit, but also I think at the end of the day, one of the things that was happening, especially after the modern day lynching of George Floyd, was that we were being asked, like, yes, nothing without you, nothing for you without you. And, can you help? Can you do this? Can you do that? Can you provide input? We are having, and I was getting really angry because pay us, like, damn it, pay us for our work, pay us for fixing the problem that you created. Like, or even if it's within a work context where the person is being paid, at least acknowledge that they're probably going to get a benefit, or, that this is work that's going to be done in lieu of something else that they're going to do. There has to be a way to acknowledge that this is not something that should be an additional burden on them, and how are you going to remove that burden? And again, this is something that our allies or people in leadership, again, should be thinking about when they are asking their, and I don't really like the term BIPOC, but I'll use it for the sake of this question, their BIPOC community members are experiencing and therefore they need help with. It's fine to ask for help, but it's also important that you acknowledge that this person has an existing life like everybody else in your workplace. They have an existing life with existing struggles, with existing challenges. And now you're saying, hey, Black girl, can you also help me with my challenge of not being able to understand you, and do it without any benefit? Well, thanks. But that's an extra tax that I just don't feel like paying. So, and sometimes if there's a, oh my God, my mind is slipping, a hierarchy, like if it's your boss, you can't say no. So you feel like, well, damn it, now I have to say yes, but I'm not even getting any benefit. Like, I still have my work to do, and now they're asking me to do like this Black stuff. Like, at least in leadership, acknowledge that and say, okay, I understand that I want you to do this. Make some negotiation. I don't know what the negotiation is, but either pay them or give them a benefit for doing the work that they're doing.
Absolutely, Celina. Really good food for thought, and for others to think about as they approach people of color and others, and recruit their help, or try to invite them for their help. Yeah, absolutely. There are a few more questions coming in. I'm mindful of the time, so maybe we can have this too as the last ones. There is one. As a faculty member and researcher, I work diligently to be aware and avoid missteps, but I must admit that I'm more and more wary of how I'm being perceived. I'm rarely, if ever, approached by colleagues, students, or patients with concerns. This makes me believe that it's not my diligence, but reflects the difficulty that others have in pointing out concerns my behaviors have raised. How do we avoid the fear without withdrawing into ourselves or becoming other than ourselves? Great question.
It's a really good question.
Good question.
So I'll just say a couple of quick things from me. One is, it's great to have this faculty member or researcher has acknowledged this. And just by being a faculty member puts someone in a position of power, so that as Celina just said, students or patients may not feel comfortable to be able to say, hey, you just offended me by what you said or what you did. I think, I hope we will, in our continual cultural transformation here, make this into the safe kind of space that will allow people to be able to increasingly find ways to speak up. Sometimes I think we do need to give people permission to speak up. And I would say just the other thing is that for me, sometimes the more time I spend with somebody who can teach me, and Celina has taught me a lot, and other friends who come from different backgrounds have taught me a lot. Just tonight, I've learned that Celina doesn't like the term BIPOC. So I'm like, okay, next time I'll first of all take time to ask her, not assume why she doesn't like that term. So I'll make a mental note of that. For those who didn't already know before tonight that she doesn't want anyone to touch her hair, now we know, and maybe somebody didn't know that, and she's really good at telling us those kinds of things that we might not have realized. But I think the more time that we spend getting to know one another, the more we can hear someone make those kinds of general comments that raise all of our awareness of the fact of what might actually be offensive. But I'm going to pass it over to Celina to give a better answer.
No, you know what? I agree. There has to be those conversations. And, I always tell people that if you are talking to the same people today that you were speaking to 5 years ago, you need to have different conversations. You need to start engaging the unusual suspects. You need to be engaging people that you often intuitively think have great ideas, but are very silent at the table, especially as leaders, very silent. The person that's always talking, and when they speak up, people around the room go like this, like that wasn't his idea, that wasn't like their idea, it was my idea, so you have to be able to read the room and sort of talk to those unusual suspects, and understand their viewpoints. The other thing is, when you talk about how do we avoid the fear without withdrawing into ourselves or becoming other than ourselves, I think that's critically important. And I have sort of 3 things that I would say to that. The first is, let people know that you're learning. Like, let people know that you're learning about this stuff and that you're willing to learn from them. There is no hierarchy here when it comes to this kind of learning. In fact, you might be the minority in understanding what it is that individuals, racialized individuals, persons with disabilities, different sexual orientation, religion, what they're experiencing. So you may want to be the one that says, look, I'm learning here, and I'm going to keep my door open. Like, make that an open door policy, that you want to know, you want to learn, and there isn't a consequence for that behavior. Because often we just won't tell you, because I'm like, I need my paycheck. I'm not going to tell this guy anything because I might not get my job tomorrow. And so be a little bit vulnerable. And that in and of itself strikes fear, but you have to be a little bit vulnerable. And don't be afraid to say that you're going to make mistakes. I probably made about 15 mistakes in this presentation. I'm supposed to be some expert in this stuff, but don't be afraid to make mistakes, and you're learning as you go along. So you want to make sure that people know that you're learning and that you're going to make mistakes. But you want to be called out, you want to be checked on your mistakes, and that's okay. And then lastly, just breathe. Everybody does this work and they're like, because they're afraid to make a mistake. But you're going to make mistakes, but you have to be willing to say that I'm going to make a mistake. And I think in most cases, people will be okay with saying, okay, you made a mistake, you're learning, and this is where you could self-correct or auto-correct. And then you have to do your homework. Like you can't just say, oh, I made a mistake, and then somebody says, yeah, you made that mistake, and then you just go along and marry your life. That's where you do your homework. That's where you do your reading. That's where you understand the history of where this is coming from. So there's some work on you too.
Absolutely. Thank you, Celina and Jane. This question, I think, Jane, goes back to what you were saying about finding ways to support our students in different, in engaging in this work. The question is more direct, actually. Should volunteers as part of the Dean Section Table EDI who are performing a tremendous amount of work be paid?
Great question. But by definition, the people that signed up have signed up as volunteers. We have been cognizant of the fact that it is a lot of work, and we have tried to bring extra resources to it, including folks in OpDes that are helping with the work around some of the environmental scans, etc. We're going to probably bring in additional resources so that we don't overburden volunteers, and also look for opportunities to be able to, as I said earlier, find studentships or look for ways that we can be able to say, if you want to take on this extra task, which is going to be a lot of work, then we will try to find ways to be able to finance that. So not necessarily all the time, but for certain types of work that will be offshoots of that, we certainly recognize that we don't want to overburden anybody.
Sorry, I really got to jump off now. I really do apologize.
Thank you so much, Celina. And we're actually wrapping up because we've come to the end of our time. Celina, thank you.
Okay,
thank you so much.
I apologize.
I'm glad you read some of the positive comments. There are a lot of comments as in great insights and directions. Thank you for the responses, excellent responses. And Erin, which Celina read already, we're trying to do all the work in dermatology education. We're almost there. There is still a lot more work to be done. So I'll wrap it up with your words, actually, Dr. Philpott and Jane's word about rooting our work in human rights, getting to know one another as human beings, and really we do acknowledge that we're on this learning journey together, but articulating it, something I learned from Celina, is actually taking that to the next step and telling others that we're learning and we'll make mistakes, and we need to own our mistakes and move on, and learn some more so we can do better next time. Thank you so very much. Again, we're very grateful to hear from you and Celina, but also to get that sense and that pathway and that destination, and how can we all work together to achieve that and get there. Thank you again, and thank you to everyone who made the time tonight. Have a great evening. Thanks.
Thank you.